Hello everyone, my name is Dr. Zainab Vora, your mentor for radiology at the Unacademy platform. I'm bringing to you our fourth episode in our series which is focusing on extra edge case scenarios where we look at multiple important image-based questions from radiology. So if you've missed out on the first three episodes guys, where we've covered mesial temporal sclerosis, we've talked about temporal bone fractures and its types, and pancreatitis, basically the spectrum of pancreatitis, and integrated that important topic of IgG4 related disease, which is very important, a potential question for your upcoming exams. So in case you've missed out on these classes, just go to the YouTube page of Unacademy, find my name, and you'll see those classes, all the free classes that I've taken for YouTube. Alright, so let's begin. In case you're interested guys, if you checked out Unacademy platform for NEET PG and you like what you see, there are a lot of free classes guys. Those of you who are new, please see the free classes by all the educators that are there. In case you like it, you like the interaction, the live interaction basically in the class, which is the USP of Unacademy. You can subscribe for it, where you get, once you subscribe, you get unlimited access for all the educators guys, for all the subjects, the entire thing. You get access to. If you want, you can use this code which is ZVORA, which gives you a 10% discount on your subscription price. So let's begin guys with this background. Let's begin with our case of the day. So we have a 25-year-old female patient who presents to the OPD with mild wrist pain. Physical examination is normal. So on physical examination, there's no deformity, there's no swelling, no signs of inflammation. So an X-ray of the hand was done to see what's going on. And they are asking the likely diagnosis. So we have the image right here, and the options that we need to consider are primary hyperparathyroidism or primary HPT, acromegaly, melodiostosis, and Olier's disease. So these are the four things, and guys, these are the four most commonly tested diagnoses on hand X-rays. So you need to know in detail about what all of these looks like, alright, or look like. So basically guys, remember, for each body part you need to know the spectrum of pathologies that involve it. For example, you need to know all the skull pathologies, the skull appearances, similarly spine appearances. That way you can have a systematic approach to your diagnosis, once you're presented with an image. So important areas like the hand X-ray, like we're talking about now, you need to know the entire spectrum guys. It's very important. So that is my approach with this particular episode right here. In case you like it, in case you want me to cover skull or spine or any other body part like this in a systematic manner, just type it in your comments basically, and we can have such a series in the next time. Alright, so now let's look at the image guys. Let's look at the image. First of all, this is not, although this is staring right at your face, this is not the pathology, right? This is just a ring that the patient is wearing. So just focus your attention off it. So our first learning point here is, anytime you're taking an X-ray, ask the patient to take the jewelry off, right? Which the radiographer has not done here. So first learning point. Keeping that aside, what do we see? What is the glaring abnormality here? So I see that there is this flowing sort of ossification which is involving this entire series of bones, right? So it's sort of flowing down the bone from distal to the proximal aspect, right? And it's not just these bones which are involved. It's partly involving these bones also, it's partly involving these bones also, right? So this particular appearance, remember guys, is called the flowing candle wax kind of appearance. So you can see how it looks like flowing candle wax, right? That the candle wax is melting and it's flowing down the candle. So remember, this particular appearance guys has been used three places in radiology. One is this particular entity where you are seeing this flowing ossification through the bone. The other entity where you see this flowing ossification along the anterior aspect of vertebral body, something that was very recently tested in the AIIMS paper, right, where you have the ossification, the flowing ossification of the anterior longitudinal ligament. And this particular entity guys tends to affect older patients, right, tends to affect older patients than 40 years at least. Then basically it tends to involve the cervicodorsal spine. So all of these points, remember, go in favor of a diagnosis which is called DISH, which stands for diffuse idiopathic skeletal hyperostosis. And remember, this is a differential for ankylosing spondylitis, and this is the fact which was tested in the AIIMS exam. So remember, ANSPON will have reduced IV disc space, First differential. Second difference being that it's not just the anterior part which is involved in the angstpon. There is a pan joint fusion of the spine which happens, leading to a very rigid spine that happens in angstpon. Thirdly, the demographic, very different. It tends to affect younger boys. Alright, so just integrating our facts so that it's a better recall. So anytime you study any topic, try and recall maximum things related to it, such that if you keep going back and forth from that topic, your memory becomes much more stronger. So that is how you remember better. So coming back right here, so we had dish which also showed this appearance. Then in the brain, guys, remember in the subependymal nodules, basically the nodules which are located along the lateral ventricle in a syndrome, in the neurocutaneous syndrome, which is tuberous sclerosis, we have this calcification which develops. So remember, the subependymal nodules will calcify as the age progresses. Again, this appearance is likened to flowing candle wax. So coming back to this, so now what do you think is the likely diagnosis? So the likely diagnosis here is melodiostosis. Alright, so remember this image. Once you see this, I don't think you'll ever forget the stark, glaring, flowing wax kind of ossification which is associated with a disease which is called melodiostosis. Now very briefly, let's talk about this disease, melodiostosis, which is also called as Lery's disease. Alright, it's called as Lery's disease. It's a type of a congenital dysplasia which involves the mesenchymal soft tissues. So remember, it's a congenital disruption in the development of the bone because of mesenchymal dysplasia. So although it will be at birth, very rarely does it present with symptoms. Alright, so clinical features, remember, mostly in the majority of the cases it will be asymptomatic and usually will be an incidental diagnosis for an X-ray done for some other reason. Alright, so very important, usually asymptomatic, very rarely it can have mild pain, like the one that we had in our case scenario where the patient came to us with very mild pain. Right, so remember, mostly asymptomatic, incidental diagnosis, radiological diagnosis, rarely patients can have mild pain. And the appearance, as we saw, is the flowing wax kind of appearance. Remember, distribution wise, so distribution wise it tends to affect one limb. So it is typically monomelic, but it is not usually monoostotic, as in not just one row of bones. As you can see here, it tends to involve the other rows also. So monoostotic not so much, but monomelic usually involves one limb, and you will see this flowing ossification linearly along the series of bones. Alright, so very typical appearance, guys. Remember this image, this is melodiostosis. Now let's study the other diseases which involve the hand. So what is this, guys? Very important image spotter. No history, just this image we can make the diagnosis. So what do we see, guys? We see that multiple bones are involved and there is this enlargement. There is an expansile lesion, right? The bones are expanded and there is this irregular expansion. And what is the other feature that I see, guys? I see that there is this stippled calcification. Can you see these tiny specks? So guys, remember, hand bones, the tubular bones of the hand being involved, a lytic expansion. Basically, you are not seeing new bone formation, right? In contrast to melodiostosis, where I had whiteness being increased, basically sclerosis or ossification. Here, I have destruction, which is lysis of the bone, correct? So, lytic expansile lesion with stippled calcification, right? With these tiny bright spots. Remember, multiple bones being involved, the diagnosis will be multiple enchondromas. Alright, so the diagnosis with this appearance is enchondromas. Now, if a single enchondroma is there, it's just one enchondroma. But if there are multiple enchondromas, I have to look for something else. So, I have to look for hemangiomas. Remember, to ultimately call something the syndrome, I have to rule out whether there are hemangiomas or not. So, clinically, we'll see hemangiomas as bluish swellings. So, the patient will have multiple nodular sort of bluish swellings on the hand. But on the X-ray, what I will see is, I will see these tiny white calcifications basically, which are called phleboliths. Alright, which are called phleboliths, which are these calcifications which occur in hemangiomas. So remember, guys, enchondromas plus hemangiomas, or enchondromas minus hemangiomas means only enchondromas, multiple enchondromas but only enchondromas, no hemangiomas. What do I call it? So O for only enchondroma, it's Ollier's disease. Alright, so multiple enchondromas can have two syndromes. If there are only enchondromas, we call it all ears. If there are multiple enchondromas in addition to multiple soft tissue hemangiomas, we call it the Maffucci syndrome. Alright, so remember these names, guys. The Ollier syndrome, the Maffucci syndrome, very frequently asked. Alright, so we've covered two pathologies of the hand: melodiostosis, flowing ossification. Second type, multiple expansile lesions of the hand bones. We have to think of multiple enchondromas, Ollier syndrome, or if there are hemangiomas in addition, I think of Maffucci syndrome. Alright, now let's look at the third pathology, guys. Look very carefully. What do we see here? What we see, first of all, if you just look at the soft tissue, right? X-ray, remember, is not just for the bone. We can definitely see the soft tissue, right? I can see that the soft tissue here is so thickened. Can you see that the person's hand, the soft tissue is so thick? The fingers are so stubby, basically. I see that the soft tissue has thickened markedly. So our first point that we have noticing is that the soft tissue is thickened. The second thing that I am seeing, guys, in the phalanges, can you appreciate that the distalmost phalanx basically looks like a spade? Can you see that this particular phalanx, everywhere there is this overgrowth which is occurring? Can you appreciate this? So this is called spade-like phalanges. So these are called spade phalanges, alright, look like spades. So this is a very, very typical feature. Apart from that, what I see is that the joint space again is widened. So there is proliferation of soft tissue here and there is proliferation of intra-articular soft tissue, right? So there is synovial proliferation also, which is leading to this widened joint space. So adding all of these things, basically I start to think of a syndrome basically which is acromegaly, which is produced most commonly because of a pituitary adenoma that produces growth hormone. So a pituitary adenoma causing overproduction of GH, particularly after fusion of epiphyses, right, in a skeletally mature patient. Otherwise the patient will have gigantism. If the patient is skeletally mature, he will have acromegaly. Now let's add up the features of acromegaly. Let's consolidate all our knowledge at the same place. So the other features, guys, again the skull appearance will be very, very striking. So what are the things I have to look for in the skull X-ray, guys? First of all, we will see that the sella is widened, the sella is increased in size. So you see this ballooning of the sella, which is again because of the pituitary adenoma that we have, which is producing the GH in the first place. So first feature, the sella is widened. Second thing what I see, guys, is that the size of the sinuses, the frontal sinus, the maxillary sinus, it's all increased. So increased size of the sinus, second feature. Third feature I see is that the jaw is protruding frontally. So this is called prognathism. Alright, so an increased angle of the jaw, basically a more prominent angle, prognathism, is the third feature. The fourth feature I will see, not seen here, is caliberial thickening. So if the skull bone is given, guys, here I have focused on the face, but if the skull bone is given, the calvarium, the skull bone will be thickened. Alright, again all of this has got to do with increased production of growth hormone, which produces a thickening of the soft tissue and the bones. Alright. So very, very typical appearance of the face X-ray, guys. In addition to our hand X-ray, start thinking of acromegaly. All of these findings very, very important. And the hallmark, nowhere else will you be given this X-ray, guys. So whenever you are given this X-ray with the heel thickness being increased, remember it's almost pathognomic for acromegaly. So what do I see here? I see that the heel pad thickness is increased from normal. The soft tissue of the heel is so much more thickened, guys. If I have to give it a number, remember it should be more than 21 mm in females and more than 23 mm in males. So this is the normal thickness. Basically, if it increases, we call it a thickened heel pad, just to make it more reproducible, right? So remember, these measurements not important, but the increased heel pad thickness, start thinking of acromegaly. It won't be seen in anything else. Alright, so this is the spectrum of abnormalities seen with acromegaly. In the hand, what did we see? I saw that the soft tissue was thickened. There are spade-like phalanges, again an important one-liner. Again, joint space might be increased because of synovial proliferation. Alright, and one more one-liner for you. What is the screening investigation? If they ask you what is the screening investigation of choice, if I see this X-ray, Remember, answer will be IGF-1 levels. So we will do IGF-1 levels, which will be an initial investigation of choice in a suspected case of acromegaly. Alright, so with this background, let's look at the fourth pathology that we have here. Very, very important. So out of all the things that we have seen in today's class, guys, this is the most commonly tested. This is the most important one that we need to know of. So what do we see here? What do we see here? So we see that in the middle phalanges, most prominently towards the radial aspect, basically in the phalanges towards the thumb, I see that there is this resorption. It looks like the bone is eaten up here, right? There is this asymmetricity where the bone looks eaten up. So this, remember guys, is the pathognomic finding which is called subperiosteal resorption of bone. So I have the bone which is being resorbed, which is being eaten up. So subperiosteal resorption of bone affecting the phalanges, the proximal and the middle phalanges on the radial aspect, particularly affecting the second and third digits. This is all very, very pathognomic, very, very important for hyperparathyroidism. So our option A in the question, hyperparathyroidism, will show this kind of appearance. Very, very important, guys. I cannot stress this enough. This is a very important X-ray. So again, just to consolidate, what are the other findings of hyperparathyroidism? So remember, hyperparathyroidism can be of three types. It can be primary HPT if it's because of a parathyroid adenoma, which is producing more parathormone. It can be secondary because of CKD. So you have CKD because of which you have your calcium levels which undergo depletion, which results in secondary activation of parathyroid, and this is called secondary parathyroidism and secondary hyperparathyroidism. And the third part is a tertiary HPT, the rarer type, where you have this background of secondary HPT, but because of this continuous overstimulation of the parathyroid gland, guys, what happens is it undergoes autonomous activation, that there are changes of primary plus secondary. Alright, so that is the tertiary HPT. Now with this background, let's look at the other manifestations. So what is this skull showing? Again, very important. So this is the salt and pepper appearance. You see that there are multiple tiny areas, right? There are multiple tiny areas which represent the black pepper. So these are the lytic areas, right? The bone is eaten up. In addition, you have some white areas which are the residual bone. So this tiny resorbed bone, again because of resorption of bone. So what is the action of parathyroid, right? Again, everything, if your concepts are clear, imaging findings are just an expansion of that. So parathyroid hormone basically will eat up the bone, right? It will release the calcium and phosphate from the bone, because of which you have these tiny foci of bone resorption. This is given the name salt and pepper appearance. Again, very important. In the bones, guys, what we have are these multiple lytic lesions. So remember, there are multiple lesions, again like enchondromas, but typically tend to affect the long bones. Okay, so multiple lytic lesions which are called the brown tumors. Alright, so these brown tumors also associated with hyperparathyroidism. What am I showing you in the teeth right here? So remember, guys, there is a layer which appears white on X-ray, which you can't see here. So this is again the abnormal appearance, which is loss of lamina dura. So lamina dura is this layer basically which on a normal X-ray appears like this thin white line right here. Alright, so this gets lost. This again gets resorbed because of the parathyroid hormone. So this is again one of the important features that we see in the X-ray. What about the spine here, guys? What is the name of this spine? I'm sure a lot of you know this. So this is the Ruger-Jersey spine. Alright, so this is the Ruger-Jersey spine, and this is typically more commonly seen with secondary HPT. So in secondary hyperparathyroidism, I have more sclerosis. In primary, there is more lysis which occurs, whereas in secondary, a higher sclerosis happens. So what I see in this Ruger-Jersey spine, the pathognomic finding, are these end plate sclerosis which give the name of alternating white and black stripes, right? Likened to the jersey of a rugby player. Hence the name Ruger-Jersey spine. Alright guys, so again I have covered this topic of hyperparathyroidism in great detail in my class on metabolic bone diseases. In case you have not seen that, it's a free class available on Unacademy. It's a very high class guys, where we've talked about rickets, scurvy, hyperparathyroidism, osteoporosis, a lot of integrated things. So please have a look at that. It's a free class readily available for all of you. Alright guys, so that's it for this particular class. I hope you like this integrated approach where we look at a spectrum of pathologies involving a part and systematically, approach it and systematically remember it much better. Thank you guys. I hope you liked it. Please comment and give me your feedback so that I can give you more such useful classes. Alright guys, thank you. Bye-bye.